Hello, everybody.
Yeah, good evening all. So before commencing this class of EDIC Part 2, I have a special announcement. As you all know that EDIC Part 2 examination result got declared yesterday, and I'm elated to announce that from our Farz Academy, there are aspirants who successfully passed this EDIC Part 2 exam, and we will arrange a special class for you all which would be taken by our successful candidate as they will share their feedback, tips and tricks about the examination format. We will inform you about this class, special class, through mail and WhatsApp group in due course. So this was an announcement, and now we can proceed with our class. Our today's speaker for the topic GI is Dr. Mohammad Saif Khan. He is a consultant intensivist in Department of Critical Medicine, King Hamad University Hospital at Kingdom of Bahrain. His area of expertise are in critical care ultrasound, echocardiography, bronchoscopy, percutaneous tracheostomy, AKI and CRRT, HFNC, and mechanical ventilation. Yes, sir, you may proceed.
So, welcome to this session on gastrointestinal critical care. And my name is Dr. Saif, and I'm working in King Hamad University Hospital, Bahrain, as a consultant ICU. And welcome again to this session. And recently, we had EDIC Part 2 exams in which many candidates have passed it successfully. And many have been in touch with me before they started the exams, especially in Bahrain, some of my juniors and the registrars basically. And they said that it was quite difficult when they appeared for the exam, but later they've all passed. It means that this time the difficulty level was very high compared to the last year, but because they were all clinically oriented and working in ICU, and they devoted about 15 days before the exam to this, so they could successfully pass. So this is very nice. And again, I would say that this is difficult, getting difficult day by year. So you have to be very, very thorough with your critical care. So with this, I would start my session, and this will be interactive. And I'm sure that all of you are practicing intensivist already, working in ICU. So it will be easy. Okay, so shall I proceed?
Yes, sir, you can.
Okay, fine. So I have divided my session into two parts. Today's session into two parts. The first one would be the clinical case scenario. So I would present only two scenarios, the detailed one, because we don't have much of time. But we'll include most of the GI topics. As you know that in exam, in one CCS, you would get 3 or 4 systems together. Okay. And it will change from vignette to vignette. So you have to be like very open minded and try to answer all the question. As I said, that each question has various answers, about 4 to 5 answers, and you keep trying answering. Okay, because sometimes examiners have different sets of answers, and they will match your answers and they will provide you marks. So never hesitate to answer. That is what I want to say. And with this, I would start the CCS GI part 1. Okay, so in CCS, we have different topics, potential sources of CCS, like GI bleeding, hemodynamically unstable patient with GI bleeding, upper GI or lower GI bleeding, and we can have a perforation peritonitis patient in the pre-op, or may go into the post-op ICU, and then you have to manage that. Acute pancreatitis, cholangitis, cholecystitis all together, and then we have acute mesenteric ischemia, chronic liver failure with upper GI bleeding specifically, and abdominal compartment syndrome. So abdominal compartment syndrome cannot come as a predominantly CCS. It may come as just a one VNet in the whole CCS. Okay. So, but other topics are very, very important, because any topic can be presented to you in the form of CCS. So here on the screen, This is the vignette 1. A 60-year-old lady, known case of type 2 diabetes mellitus, chronic liver disease, and end-stage renal disease, on maintenance dialysis 3 sessions per week, left breast cancer and osteoporosis, presented to emergency room with 2-day history of shortness of breath, chest pain, and orthopnea. There is high sensitive troponin T elevation, and cardiologists advise to start on dual antiplatelets and systemic therapeutic anticoagulation with unfractionated heparin infusion. There was prior history of a hospitalization with similar complaint 1 month back and diagnosis of right hepatic hydrothorax. She also underwent diagnostic thoracentesis and ascitic tapping. She was managed conservatively and discharged after a stay of 1 week in the previous hospitalization. Now, in the present hospitalization in ER, dialysis was started in view of pulmonary edema. However, she developed hypotension during dialysis, BP 70/50, for which 100 ml of 20% albumin was administered and dialysis was stopped. However, hypotension did not respond to albumin bolus, hence infusion of norepinephrine was started and she was shifted to ICU for further management. In ICU, she is conscious but speaks irrelevantly. Right arm NIBP 99/60 on any infusion 0.12 microgram per kg per minute, heart rate 90, RR 18, SpO2 100% on nasal cannula 4 liter per minute. On examination, respiratory system shows right-sided lower zone decreased air entry and crepitations. CVS shows normal. Abdomen mildly distended, soft, bowel sounds present, no tenderness. She was commenced on CRRT with negative balance of 500 ml. Heparin infusion with VT protocol was also initiated and continued, and she had right-sided jugular permacath, left EJV through which NE is ongoing. Chest X-ray on the day of ICU admission is here as follows. Okay, so from here we move on to the questions. Okay, so there is one more. She was started on meropenem and vancomycin for the suspected UTI and suspected community-acquired pneumonia, and she was recovering hemodynamically and received 2 sessions of CRRT. However, on day 3 of ICU stage, she passed large fresh bleeding per rectum, and there was significant drop in hemoglobin, 6 gram per deciliter from 9 gram. Noted along with a sudden increase in the norepinephrine infusion dose to now 0.2 microgram per kg per minute. Our ABG is as follows. So this is the ABG in front of you. pH 7.23, PO2 80, PCO2 26, bicarb 14.9, potassium 3.99, sodium 139, chloride 99, and lactate 11.5. Our important laboratory parameters obtained during this episode of bleeding are hemoglobin 6 gram per deciliter, WBC 15,000 per microliter, platelet 63,000, INR 2.2, APT 35, and fibrinogen 1.3. So this is the whole scenario. So now you must have the summary of the case in your mind before you start answering the question. So what is the immediate management approach?
So it is airway resuscitation method. It's initially include the ABC with airway breathing and circulation. Here the patient is having severe hypotension. So resuscitation with fluids and blood products.
Okay, very good. So yeah, so increase in the norepinephrine, and this is the suppose if somebody asked you before this question, how will you summarize the case? So this is the case of 1, 2, 3, 4. So now that you start with the immediate problem. So immediate problem here is the hemorrhagic shock. Okay, due to which there is a sudden increase in the norepinephrine dose. Okay, and the background there is a suspected community acquired pneumonia as well as some suspected UTI. So this is your summary, and now you start with the ABC, right? Then what else? What will you do? The definitive management? Anything? Blood and blood products management?
Yes, sir. Next, we identify the source of the bleeding and to stop the bleeding.
Very good. Okay, and anything else? So immediate GI. So imagine always. So in exam, imagine and try to answer fast because you don't have much time. I mean, don't let examiner to prompt you. Okay, so 1, 2, 3, 4, 5. Always keep in mind at least you have to answer 5 points, 5 to 6 points at least for each case. So ABC is 1 point, and hemoglobin, for hemoglobin drop you have to start a blood and blood product. So you order cross match and start transfusing the blood and blood products, okay, FFP and blood, ARBC, and then you make a target of how much hemoglobin you want to keep, at least more than 9 gram per deciliter, because this is a cardiac patient, so you need to keep hemoglobin more than 9 and the platelet at least 50,000 to 1 lakh, and also INR less than 1.5. Okay, so this will be your target, and you keep monitoring the coagulation parameters and transfusing the patient. Apart from that, definitive management would be to exclude the upper GI source and to start to talk to the GI, okay, gastrointestinal gastroenterologist to perform the endoscopy. And simultaneously, if this patient is this is the patient who is on vasopressor already, so because this is a very large bleed, very significant bleed, so maybe there is source in the abdomen, I mean some arterial bleed. So for that you have to go for CT angiography also, and you have to hold antiplatelet and anticoagulation, because remember, for this patient came with the non-ST elevation MI, so probably this has to be discontinued, and if required, vitamin K, because this is already a liver case, and prothrombin complex concentrate if INR is more than 2.5, because this patient has just INR 2 point something, so that you can consider later, but vitamin K definitely. So these are the points you have to answer. What could be main reason for lower GI bleeding? So here they are asking you the causes. So 1, 2, 3, 4 important causes in this patient.
The use of anticoagulant and antiplatelets.
Okay.
Diverticula.
Diverticulosis, yes, old patient diverticulosis is very common.
So mesenteric ischemia. Her lactate levels were increased.
Ischemia, yes, very good. And colonal polyp, colon polyps also maybe cause some rectal ulcers, ulcerative bleed, ulcerative colitis also. Okay, anything. Apart from that, so if it is child, makes diverticulum, but this is adult patient, so most common cause will be diverticulitis, followed by hemorrhoids and the ischemic colitis. So you are right. Now, what are the definitive therapeutic options to control lower GI bleeding in this patient? So in this particular question, they are asking about the definitive management. 1, 2, 3.
Colonoscopy and sigmoidoscopy, and
Yes.
management according to what we get.
Very good. So endoscopic management and the angiography. Okay. So CT angiography and embolization of feeder vessel, endoscopic management, and surgery. Only 3 options are there for even for upper GI bleeding. 3 options. Now the order can be any. Either you do first endoscopy followed by CT angiography and surgical, but you have to answer all these 3. These 3 are the main definitive therapeutic options. Okay. Right. Now, what are various endoscopic treatment options available for lower GI bleeding? So this is a question for from the gastroenterology point of view, but you must know so that you can discuss these options with your gastroenterologist. So examiner would like to know how much is your knowledge regarding gastroenterology point of view, so that you can open up discussion with the GI. So what are the various endoscopic treatment options? What they are supposed to do, what they will do? So in this, there are various options like ligation of feeder vessels, or even they can thermocoagulate. Okay, they can use the laser, argon laser thermocoagulation. So these are and also sometimes they can clip. So clipping is also available, right? So this you must understand. And also apart from all these, so these are the endoscopic maneuver by which the endoscopist would be able to catch up the bleeder. Apart from that, epinephrine injection is also very useful, right? So adrenaline local injection is also used along with all the endoscopic treatment. What is the role of upper GI scopy in lower GI bleeding? This is a very common question they might ask. Is there any role?
Yes, sir. 10 to 20% of upper GI bleeds present with lower GI melena or.
Very nice. So for this you just have to remember the algorithm, right? So in algorithm, they say you have to look for the upper GI source also. So if the patient doesn't have, and this particular patient definitely has the NG already, rise tube or nasogastric tube. So you have to ask the sisters to flush the saline and just aspirate the material and see if there is any change in the color to hemorrhagic one or coffee brown color, something like that. So you have to exclude that. And if it is positive, then you can go for the endoscopy, upper GI endoscopy. So 10 to 15% of lower GI bleeding may have proximal GI source. And now there are some risk factors in which you would consider it definitely, like if the patient has history of peptic ulcer bleeding, or is there any history of portal hypertension. In this particular case, patient is already having CLD and had previous hospitalization. So definitely that very high risk of upper GI bleed. And if patient has BUN upon creatinine ratio more than 30, or aspirin or any anticoagulation use, or positive nasogastric lavage. Okay, so these are the risk factors. Even if the patient is on the hydrocortisone or some steroid therapy, that also is very considered as important risk factor. Now we will move on to vignette 2. Fine. So trachea was intubated and mechanical ventilation was started with sedation, remifentanil and low dose propofol. And rectus sigmoidoscopy was performed, which showed rectal ulcer with bleeding vessel, treated successfully with hemostasis. 3 packed cells were transfused along with 4 FFPs, and norepinephrine requirement significantly decreased thereafter. However, after 4 hours, again there was hypotension and there was fresh rectal bleed which was discovered by nurse, and patient was sent to radiology suite where a superselective cannulation of superior rectal artery showed evidence of vascular congestion and blush at the right side. Coil embolization of SRA was performed. Patient was shifted back to ICU. Hemodynamics stabilized. Lactate level remained more than 4. However, hemoglobin was stable, not dropping. Okay, so this is the scenario. So in this scenario, you have seen that this patient was first managed with the endoscopic treatment, but it was not successful. There was a rebleed. So examiner might ask you, what is the rate of rebleeding, both in upper GI and lower GI bleeding? Okay, so there are different rates of incidence of GI bleeding. So they might ask you about just to knowledge. But so I have just set different types of questions. What are the causes of persistent high lactate in this particular case? Why lactate is still more than 4? The hemoglobin is normal.
CLD.
Yes?
Liver failure, infection, sepsis.
Yes, very good.
Septic
So
shock.
sepsis.
Use of
septic shock.
vasopressor.
And anybody?
Possible intestinal infections, gangrene.
Gangrene, yes. So before gangrene, some ischemia. Okay.
Mesenteric
So
ischemia.
remember that any embolization carries the risk of bowel ischemia also. So if lactate remains persistently high for next 24 hours, there is very high risk of bowel ischemia. Okay. So ischemic colitis or mesenteric ischemia and new onset sepsis. Very, very nice. I mean, you have really guessed answers. Okay. What are further management options in this case?
To follow sepsis bundle, sir. Then,
okay.
Then fluid resuscitation if needed, and then a bowel rest if it is suspected ischemic colitis or anything.
Okay. Bowel rest. Then you will follow the lactate monitoring. Yes, isn't it? Yeah, that is very important. VBG monitoring, and you try to reduce the vasopressor if you can. But in this particular case, vasopressor requirement is coming down already. But this is also one of the steps of management. And so CT angiography to rule out bowel ischemia again. Okay, after embolization, suppose lactate is not coming down, you have to consider CT angiography. And later laparotomy if it is ischemic colitis confirmed. Okay, so these are the further management options. It is not needed to go for them, but at least you should have these 2 things in mind, considering the ischemic colitis. And other, like, you have to control the sepsis, follow the sepsis markers, and try to change the antibiotics. Okay, if you have culture obtained by now, because this particular patient has pneumonia and UTI suspected, so you have to collect the cultures reports, antibiogram, and give the proper antibiotics, because this patient also has the previous hospitalization. There is high risk of MDR, right? So you have to tell all these. I have not included in the answer, but this could be the probable answers. What are the main indications for surgery in a case of lower GI bleeding? So this is not in this case, but this is a general question. You should be able to identify what is. Sometimes they might ask you very general question unrelated to the case. Okay, so you have to keep in mind. So this is just a general question. What are the main indications of when will you consider surgery in a case of lower GI bleeding?
Endoscopic methods fail.
Yes.
If it is torrential bleeding with the source unidentifiable, then also we can go for laparotomy.
Yeah, even source unidentified and rebleeding. Suppose both endoscopy and embolization both are not able to control the bleeding, and if there is further hemoglobin drop, you have to go for surgery. If the patient has, just now I told you, I mean, if the patient is developing complications, ischemic complications, then also you have to. And if there is particular diagnosis like diverticulosis, okay, or some cancer is there, suppose very big cancer which is bleeding, then also you have to think of surgery. So there are particular indications: localized bleeding with failure or inability to achieve hemostasis via endoscopic or radiological interventions, the need for curative resection. Okay, so these important.